and she is also a national diabetes educator. That's wonderful credentials. Thank you so much, Ms. Padmavati, for being with us in spite of being sick. She also has a lot of research publications at both national and international conferences. She has an expertise in maternal and child nutrition, diabetes, non-communicable diseases, HIV/AIDS, public health nutrition, and many more areas. Thank you so much again, Ms. Padmavati, for being with us. Moving along to our last but not the least you remember, Ms. Anita Shah. Ms. Anita is also a senior dietitian with Manipal Hospital in Siliguri, and she is expert in clinical and therapeutic nutrition, including ICU and critical care nutrition support. She has lots of hands-on experience in enteral and parenteral nutrition planning, very strong and proficient in disease-specific diet planning and evidence-based nutrition care. And Ms. Anita Shah is also experienced in patient and family counseling for long-term disease management. She has proven ability to work effectively within multidisciplinary healthcare teams, a former dietitian at Apollo Hyderabad, and she completed her clinical internship at CMC Vellore and Osmania General Hospital, Hyderabad. Ms. Anita is actively involved in conducting health talks, workshops, and nutrition education programs. Her academic credentials include a master's in clinical nutrition and dietetics and a postgraduate program in adult nutrition from American Association of Physician Care. Coming to her professional highlights, she has expertise in tertiary care, hospital nutrition services, and conducts a lot of health talks, workshops, and nutrition education programs. So that's about our wonderful jury members today who bring a lot to the table. And we will move along to our next segment. The way this program is conducted is we have four participants in today's contest. Each of them will have about 12 minutes of time, and 10 minutes is for them to present and 2 minutes is for the jury members to ask questions. All the jury members are provided with the evaluation sheets, so you will be using those evaluation sheets to evaluate our contestants. So contestants, I request you all to please stick to your timings and make sure that you are not going over your time because you are marked for that as well. So moving along, our first contestant is Namna Abhiya Alex. Are you here?
Yes, ma'am.
All right. Good. So if you can just, there you go. I see your happy, wonderful face. Thank you so much. Mr. Sai is going to share your presentation. You have about 12 minutes, Abia, and I need you to please stick to your time. At 8 minutes, I will let you know that we are, close to your time, and then make sure you space out your presentation in that way. And you'll have 2 minutes to answer any questions. Sai, are you ready to share the presentation?
Yes, ma'am.
Okay, so let's get started. Your time starts now. Go ahead.
Good evening, one and all. My name is Nanma from HCG Bangalore. So today I'll be presenting a case on carcinoma, left lateral border of the tongue. Next slide, please. Oral cancer is a malignant neoplasm arising from the tissues of the oral cavity, most commonly squamous cell carcinoma, and it is frequently associated with risk factors such as tobacco use, alcohol, and betel nut chewing. Next slide. Okay, so this was a 20-year-old male who's from Dhaka, Bangladesh. He's a computer science engineering student, and he had no comorbidities, no family history, no habit history. He was admitted on 8th October and discharged on 18th. Next slide. So in the month of August to September 2025, he noticed a small ulcer on the left side of his tongue, where then he met a general physician. And then when the ulcer was not reduced and it did not heal, he revisited the physician and was referred to oral and maxillofacial surgeon. On September 2025, MRI scan showed infiltrative growth at left lateral and posterior tongue, measuring 2.5 to 1.5 centimeter plus submandibular lymphadenopathy. And a biopsy in September 2025 showed well-differentiated squamous cell carcinoma of tongue. Further, he was referred to HCG Bangalore. And on October 4th, the PET-CT was done, which showed metabolically active soft tissue lesion measuring 3.3 into 1.1 centimeter and prominent left level 1B lymph nodes, largest measuring 1.4 into 0.7 centimeter. Next slide. So thus, he was diagnosed with carcinoma of left lateral border of tongue, and the surgery was done on October 9th, which was left hemiglossectomy with robotic left MRND plus teeth extraction plus left lateral arm free flap. Post-operative day 1, October 10th, re-exploration of neck due to hematoma in the neck under general anesthesia was done. He was NPO. From POD 2 to POD 9, patient remained stable with gradual reduction in neck arm drain output. Initiation advancement of RT feeds to full strength feeds 200 ml second hourly, and intermittent fever episodes were managed. He was discharged on POD 9 on medications with continued full strength RT feeds till clearance from plastic surgery team to initiate oral diet after 1 week of discharge. Next slide. So now I'll be presenting based on the NCP process, that is a nutrition assessment followed by diagnosis, nutrition intervention, and nutrition monitoring and evaluation. Next slide. So the nutritional screening and assessment pre-op, it showed that he had a weight of 63.4 kg. He was also allergic to banana, curd, and corn. Next slide. Next slide, please. Nutritional screening and assessment, it was done through SGA form, and it was rated, he was rated as well-nourished. Next slide. The GLIM criteria was done next. So that also showed the diagnosis as well-nourished, where the phenotypic criteria showed less than 5% weight loss, normal BMI, normal muscle mass, and the etiologic criteria showed reduced food intake due to oral ulcers, and disease burden inflammation was there. Next slide. So the PES statement stated that though the patient was well nourished pre-operatively, increased nutrient needs related to hypermetabolic state or disease burden and surgical stress secondary to carcinoma of the left lateral border of the tongue with hemiglossectomy and neck dissection, and need for enteral feeding with calorie and protein dense feeds. Next slide. The nutritional intervention showed the goals, and it was calculated as energy, providing 1,900 to 2,000 kilocalorie at 30 kilocalorie per kg ideal body weight. Protein was calculated as 80 gram at 1.2 gram per kg ideal body weight. Carbohydrate, it was around 60 to 65% of total calories, providing 300 to 350 gram, and fat 25 to 30%, providing 55 to 65 gram. So in this chart, we can see here that the nutrients were stepped up accordingly. From day 4 till post ICU and afterwards, it was stepped up. So can you show the next slide, please? So thus, we can see during the hospital stay, just like the chart shown previously, the energy was stepped up, that is from 200 kilocalories to 1,800 to 2,000, it was managed. And protein also was stepped up till 85 gram protein. Next slide. The biochemical parameters during the hospital stay. So it showed On POD3, 6.8 post re-exploration due to neck hematoma, even albumin was low. Next slide. And also this was the functional nutritional status and measurements which was calculated. And it showed that there was a decrease in the muscle mass, discharge day, and also 1 week follow-up. Next slide. This is a sample meal plan, and where nutrition education was provided to the patient caregiver with follow-up date notes. And after plastic surgery clearance, 1 week after discharge, RT was removed, diet progressed to oral liquids and soft diet. So the prescribed diet was high protein soft diet. This is just a sample meal plan. Next slide. As we come to the summary, 20-year-old young patient diagnosed with carcinoma of the left lateral trunk. Based on MRI biopsy, PET-CT findings, underwent surgery for left hemiglossectomy with robotic neck dissection, free flap reconstruction with dental extractions. RT feeds began on POD2, was gradually advanced to provide adequate calories, proteins, and by POD9, he was clinically stable, discharged on medications, continued on full-strength RT feeds, and gradually shifted to soft oral diet. Post-discharge in subsequent follow-ups. Patient was then planned for radiation therapy and still continues to follow up with the dietetic department. Next slide. Okay, so here we can see
Hi,
compared to the previous. Excuse.
you have 2 more minutes.
Okay, yeah. So in this chart, we can see that the 1 month follow-up radiation is also there. And we can see that the muscle mass has improved post-discharge. Even the hand grip strength has been good. And the CC, MUSC has also shown increase in the measurements. The hand grip strength has also showed that he has above 27 kg, shows good hand grip strength. Yeah, so this is the chart that shows that. This is nutrition monitoring and evaluation. Next slide. Thank you. Thank you.
Thank you so much. That was wonderful presentation, and you were well within your time.
Thank you.
So I now open it up to the jury members, if you would like to ask any questions.
Thank you, Deepti ji. Thank you, Namna. And first, thanks to also would want to be. I'm telling you, I'm happy to share the platform with Ms. Padmavati ji and Anita ji. And moving forward, congratulations, Namna. You've done it well within your time. I'm audible? Am I audible?
Yes, yes, you're audible.
Okay. Namna, pre-counseling, was there any pre-workup, nutritional pre-workup done for this patient? Were you able to get him before the procedure?
Yes, yes, ma'am.
Like how many days prior?
2 days prior, ma'am.
Okay, so yeah, that would not, ideally we would want the oncologist to send them so that we can do some nutritional workup at least 15 days. But I think this was quite a sudden one, right?
Yeah, yeah.
It was diagnosed
He was
and then
well nourished, ma'am.
yes, yeah, but workup is needed so that post procedure he has a good backup, right?
Yeah,
Because
correct.
then going to be catabolic state, cachexia and everything, so nutrition store anyway goes low. Okay. And I also just suggest it would be nice when you show any presentation, when you show the chart, right? RT feed charts with each feed, how much was the calorie protein that you could achieve. If you could show that, that also is good. And any other supplementation was given, probably
Yes,
that
ma'am.
also.
ONS was given to the patient.
Okay. So was
Only
it already?
ONS, ma'am, and water.
Yeah. So that was the RT feed, right?
Yes, ma'am. Yes.
That was 200 ml second hourly every time.
Yes. Yeah.
Okay. Any loose stool, GI intolerance that you observed?
No, ma'am. No.
Okay. And he's still continuing with it? Because you've been seeing him post that, and for chemo and all, you're seeing him, right?
Yes, ma'am. Yes, yes.
Is he
Yeah,
continuing with
now he
any-
has come. He's coming for radiation, ma'am. Now he's having soft diet.
Okay, is ONS still going on with the soft?
Yes, ma'am. He's taking it.
Okay. And his put on also, muscle mass has gone up, right?
Yeah.
Okay. So as such, no other thing, but just a suggestion that when you give a discharge diet, few more instructions to be given. I didn't see any instruction, discharge diet instruction, what things you will allow, what instruction you'll give, because he's transitioning from RT feed to semi-solid to soft and then to normal, right?
Yes, ma'am.
So
Yeah.
at discharge, you will give a not only discharge diet plan, but instructions also. Did you share any such slide? I'm sorry if I missed it. No, right?
No.
Is there any discharge other than discharge diet plan? I think you shared a plan, but instructions, I think it was not
It's-
shared, right? Because,
Yes, ma'am. It was given.
can you just show that? Instructions, not only the diet plan, instructions. If they can share this PPT again, just 1 minute if you can see. Is that okay, Deepti ji? Last slide, probably it should be at the end.
Ma'am, actually, all our RT feeds, diet charts, they have the instruction, ma'am.
Hmm.
It's just didn't include in the PPT. Yes, ma'am.
No, because the patient knows, but we don't know, right? So what you tell
Yeah.
to them,
Yeah,
when
but
you-
to the patient, it was explained, ma'am, with the guidelines, instructions, it's all given.
yeah. So I suggest when you present something, it has to be shown because it will make it wholesome, right? For RT feed, and when you combine RT with semi-solid, what instructions are given because they
Ma'am,
tend to.
can I share it, ma'am?
I don't know if in the time interest of time, if Deepti allows, you can. Otherwise, orally you tell. That's okay, no problem. You need not share, just orally you make me. What instructions did you give to the patient?
Yeah, okay, ma'am. If I can show you, just show you.
It's okay, Lamna, because you only have done, no? So you can just tell orally also. It's okay. We don't have to see the thing. Okay. Can't hear
Yeah,
you.
sorry, ma'am. We do mention here the guidelines. This is the chart, and here the guidelines are noted where we tell them to flush regularly, tell them to sit in upright position. All this, ma'am. This is RT feedback chart.
Yeah, understood. Understood. So because both the things you have to tell to the patient, RT feed plus transition to semi-oriented. So next time whenever you present, so include all those things.
Yeah.
Oh,
Yeah, ma'am.
sure. Thank you.
Thank you, Miss Shalini. Anyone else has any questions for Namna? No? Great. So we'll move along with our next contestant. Anaka, are you here?
Yes, ma'am, I'm here.
All right, awesome. Sai, can you please share her presentation? So Anaka, like I said, you have about 12 minutes, 10 minutes for you to make your presentation and 2 minutes for jury members to ask any questions. And your time starts now. I'll remind you when it is 8 minutes. So you'll have 2 more minutes to wrap up your presentation after that.
Yeah.
All right, go ahead.
Yeah.
Good luck.
Good afternoon to all. I'm Anakha, a dietitian from Department of Clinical Nutrition, DPS Lakeshore Hospital, Kochi. And I'm happy to share this case as part of the case study competition organized by Pulse and Nutri Health Foundation. And I truly believe that this platform will help me to guide and learn, refine my clinical nutrition skills with the guidance of this experienced and expertise judging panel. And today I will be presenting a case of chylothorax with decompensated chronic liver disease. And I will walk you through the dietary management, assessment, clinical progress, and the role of nutrition in field of recovery. Next slide, please. Chylothorax, which it refers to the accumulation of chyle in pleural cavity. And this chyle is a nutrient-rich liquid that carries the dietary lipids via the lymphatic system. And in case of conditions like cirrhosis or lymphatic obstruction, this chyle may leak into the pleural space, and that may lead for the reaction like respiratory distress and all. And although this nutrition plays a crucial role in these such conditions, because the dietary lipids may also play a crucial role for the production of chyle in this pleural space. Next slide, please. And this chyle may be produced due to different causes, that is traumatic or non-traumatic causes is there, lymphoma, then thoracic surgery, transplantation, and most importantly, in this case, it is cirrhosis. And typical symptoms of this chyle leak include difficulty in breathing, cough, chest pain, hypoxia, tiredness, and unintended weight loss. And the image here shown is the pleural drainage sample of the patient, and it is not the sample of my patient. I just given here just for a reference if any of you are not been known about the chyle and or the color of this chyle leak, and it could be beneficial for them also. And the first image, that is A1, shows that milky, that is strongly suggests the chyle leak, and over time with proper treatment and diet, the chyle color was cleared, and hence it indicates the improvement. Next slide. This is the patient profile. My patient is a 49-year-old male with a middle class background, and he is admitted in the hospital on 9th of May 2025, and the date of discharge was 17th of May 2025. Length of hospital stay was 9 days. And the anthropometric measurements of the patient, the weight at the time of admission is 65 kilograms, and the dry weight is calculated by subtract 10% from the measured weight, because he is having moderate ascites, and it is 58.5 kilograms. Height is 167 centimeter. BMI 20.9 kilogram per meter square, and the ideal body weight, which is calculated using Lemon's formula, and it is 61.3 kilogram. And the nutritional assessment was assessed using the tool SGA, that is Subjective Global Assessment, and the score was B, that indicating moderated need for nutrition. Next slide, please. These are the biochemical parameters, and these biochemical parameters helps us to identify the protein needs and also the balance, electrolyte balance. Here, the serum albumin at the time of admission, that is 10th of May, it is 2.7, and with proper treatment and followed proper diet, it was increased to 3.7, and fluid triglyceride at the time of admission, it is 124, and on 15th of May, it is 81. That is also because of followed proper treatment and followed that diet. Next slide, please. These are the vital signs that helps us to identify the hemodynamic stability of the patient. Next slide, please. These are the medications that the patient is on. TAP Utli, which is helps to break down the cholesterol that has been converted into stone, thereby dissolving the stone. Then TAP Rifagat, which it is used to treat infectious diarrhea, low absorption in both fasting and when administered with 30 minutes of a high-fat breakfast. And TAP Somorprat, which it is reduce the most of acid produced in the stomach and provides relief to gastroesophageal reflux. Syrup loose, which it is non-laxative and makes stool easier to pass by drawing water in the bowel. TAP Evin, which is worked by reducing liver fat accumulation and cellular inflammation. TAP Dietor, which is used in the management of edema associated with hepatic disease. Injection albumin, which is used in the treatment of low albumin levels. Next slide, please. This is the clinical data of the patient. The patient is admitted in the hospital because of dry cough, right-sided chest pain, and breathing difficulty. And he has a history of acute and chronic liver disease and alcoholic hepatitis with a MEDRI score of 75. And this MEDRI score is a prognostic scoring system that it is used to identify the severity of this alcoholic hepatitis and also to identify the short-term mortality rate. And here it is 75 that indicate the severity of alcoholic hepatitis. And he is diagnosed with chylothorax secondary to cirrhosis. And at the time of admission, CT thorax was taken and it revealed a large pleural effusion and the patient underwent therapeutic pleural fluid aspiration. About 1500 ml yellow colored pleural fluid aspired and investigation of fluid revealed lymphocytic with a high cholesterol effusion. That is triglycerides greater than 100 that I shown earlier. It is 124. And after 2 days of pleural fluid aspiration, the patient experienced increased dyspnea. And so plan for ICD insertion and about 1800 ml of pleural fluid drained immediately after ICD. Next slide, please. This is the diet history of the patient and it is 24-hour home record. At home, the patient intake was moderate with a non-vegetarian preference and the diet quality was poor with an insufficient protein intake and inappropriate fat distribution. And the best treatment was inadequate protein intake related to unsupported attitude about nutrition-related information as evidenced by worsening ascites and increased energy and protein needs revealed related to catabolic state of decompensated liver disease and loss of protein-rich lymphatic fluid as evidenced by high-volume pleural drainage and clinical signs of muscle wasting. Next slide, please. This is the nutritional interventions of the patient. Recommended total energy expenditure for the patient was 1740 and the calorie modification is carbohydrate is 60% of total calorie and the protein is about 20% of total calorie. Fat is 20%. That this fat is MCT based fat that it helps to bypasses the lymphatic system and reduces the chyle flow. Fiber is 20 to 35 grams, sodium is 2000 mg, potassium is 3500 mg. Next slide, please. This is the MNT goal. Short-term and long-term goals was there. Short-term goals mainly focus on to reduce the flow of these chyle and then to provide adequate protein to prevent muscle wasting and also to maintain the electrolyte. Then long-term goals mainly focus on to maintain ideal body weight, then to provide adequate or overall quality of the life, and then to maintain ensure adherence and also to prevent malnutrition. Next slide, please. This is the summary of hospital record and diet progression during hospital. On day 1, that is, we initiated with a hepatic high protein diet. After the triglyceride volume was given, we changed or shifted the diet to fat-free hepatic high protein with an MCT-based diet. And this transition also helps us to stabilize the condition of the patient. And the diet progression during hospital was given. From day 1 till day 9, the diet progression was given a graphical representation. Next slide, please. And this is the prescribed diet. A fat-free hepatic high-protein MCT-based diet was given. Also, a semi-elemental formula was given for better absorption and digestion. And we suggested to follow a strict fat-free diet with MCT helps to minimize lymphatic flow, promoting healing of chylothorax, and high protein intake compensates for protein loss through chylous drainage and prevents muscle waste. Frequent small meal improve digestive tolerance, reduce early satiety. Next slide, please. This is the comparison of hospital diet and prescribed diet with modified RDA. This comparison helps us to identify the prescribed diet that we given was almost matched with the modified RDA and the clinical needs of the patient while does not having any nutritional gap. Next slide, please. So, the patient is a 49-year-old male with decompensated liver disease and chylothorax, showed clinical improvement following therapeutic pleural aspiration and ICD drainage. A fat-free hepatic high protein MCT-based diet along with a semi-elemental oral nutrition supplement was advised to reduce chyle production, maintain nutritional status, and to support the liver function. Despite stable functional status, his discharge weight dropped to 60 kilograms, highlights the need for continued strict dietary adherence and nutritional monitoring. Long-term compliance with a prescribed diet is essential to prevent recurrence of chylothorax, preserve lean body mass, and promote recovery. Patient complaints with the diet during the hospital stay was good, but decreased complaints are observed post-discharge with time, which led to worsening of disease condition and readmitted to the hospital on 2nd of 7, 2025 with complaints of worsened chylothorax. This also reveals that a long-term nutrition is important for resolving this condition. Next slide, please. And these are the references symptoms.
Thank you, Annika. Thank you
Hi.
so much for that wonderful presentation. I would like the jury members to please ask any questions that you may have for Annika. That was wonderful presentation, by the way.
Can I ask, Deepti ji?
Yeah, please go ahead, Shalvi.
Congratulations, Anaka. Very well done. Very nicely presented as well. Confidently, smooth, presentation.
Yes, I agree. I agree with that.
Yeah.
Very confident.
So few suggestions, Anaka. When you do the BMI range, when you show the BMI range, you have to show the intent data, because for us, for Asians, especially Indians, the BMI range is 80.5 to 23. I think is the first few slides where you are showing the anthropometry. There you did it till 18.5 to I think 24.9. So whereas it should be 22.9. That is the cutoff level for us. And second suggestion, whenever you show the lab values, whichever has the abnormal value, you may highlight it so that people who are looking it just for a second will be able to grasp it fast. Yeah, being low, it will be easy for us to catch. And then one question is, how did you said 20% of the fat was managed through MCT based, right? How did you make sure it is MCT based?
That we given female MCT oil, ma'am. 5 ml thrice a day was given, ma'am.
Okay. And the cooking was?
With the female, with fat-free cooking was given at hospital, we provide that fat-free, complete fat-free with added female MCT while they having the food. At the time of discharge also, we advise to follow like that.
Okay. So in case if there's a patient who says, yeah, I want some kind of little, because not everyone is so compliant, right? So I understand coconut, of course, is MCT based,
Yeah,
but
coconut oil, yeah.
can be, it has LCT also, but MCT is more. So what do you feel, can coconut oil also be told to use while they are?
Yes, ma'am. We told them to take coconut oil. If pure coconut oil is available, then they can take that also, ma'am.
Okay. And how's the patient doing now?
Now the patient, recently the patient came to OP, and that time also we suggested him to follow a low-fat diet because he is likely to have food from outside, and also he's like to have high fat-containing food. So we advised him to follow a fat-free, low-fat diet because his triglyceride now is 46, ma'am.
And just could you understand here, because chylothorax happening because of cirrhosis is little happens so often. Could you understand why it did happen? How liver disease may pave the way for chylothorax? Did you understand the
He's having that high. Yes, portal hypertension is present, ma'am. So that may increase the pleural fluid aspiration, and also it may lead for this dilate for produce, ma'am. And also he is a person who is having alcoholic. That also liver disease may worsen. That also cause for this chylothorax or pleural fluid aspiration.
Very good, very good. Thank you, Anaka. Thank you. Good that you have understood everything. You have dived into it, and I've understood. Very good.
Okay, thanks.
Yes, ma'am.
Yes,
It's a
Ms.
very good
Padmavathy, do you have a
presentation.
question?
I would like to ask about how much fluid has been planned for this patient, ma'am? Fluid
Fluid restriction is
requirements.
1.2 to 1.5, ma'am.
Okay. And okay, fine. Okay, ma'am. Thank you.
Yeah, okay.
Thank you.
Miss Anita, do you have any questions? No? Anyone else have any questions for Annika? Okay, So let's move along. Good job, Anaka. Thank you so much for presenting. And our next presenter for today is Anusha. Are you here, Anusha? Anusha?
Yes, ma'am.
All right. Okay. All right. Is that your presentation?
Yes, ma'am.
Okay. So your time starts now. Go ahead.
Myself, Anusha, senior dietitian. Today my presentation on. Can you please share the slide? Nutritional management in acute lymphoblastic leukemia during chemotherapy. The patient came under the chemotherapy for acute lymphoblastic leukemia. Uh, we are presenting the patient journey, highlighting the assessment, diagnosis, intervention, and monitoring strategies. Slide change. Here, the patient age is 38 years old and is anthropometric 38 years old. And the anthropometric is a 58 kgs, 170 centimeters. He's in the normal. Is
Everyone else, can you
BMI
please? I'm sorry, Anusha. Please mute yourself. Everybody else. Okay, thank you so much.
is diagnosed as acute lymphoblastic leukemia, and the patient came for the chemotherapy. Can you please change the slide? Here we are presenting the patient lab parameters and the clinical course we have given. The patient doesn't have any comorbidities, but the patient have the leukocytosis value is more, and he's in the his albumin level is also low. So here the clinical course we have given at the day 2. At the day 2, here the chemotherapy was started. At the day 5, the patient, we observed the patient is having developing in the mucocytosis. And at the day 6, because of patient is not willing to take any oral feed, we have started a parental nutrition. At the day 3, we have started, after the giving the parental nutrition, at week 3, the patient is taking the oral feed. Can you please change the slide? Here, the nutritional assessment. During the chemotherapy, the patient lost the weight nearly 4 kgs, and when we have measured the MUSC, it was exactly valued 21.5 centimeters. His biochemical parameter shows that he's having the hypoalbuminemia and pure nutritional status, and the patient is under protein malnutrition. And during the chemotherapy, the patient was developing mucositis, and the patient is unable to get up. He is in the bedridden. This is the patient's history. So can you please change the slide? Nutritional diagnosis and intervention goals. Here, the patient is having a severe protein energy malnutrition because of chemotherapy. And when the chemotherapy is started, the patient is developing leukocytosis. So, due to taking consideration of all things, we have started the TPM. You can see here nutritional diagnosis. 30% of about 30% of oral intake was decreased and 7% of weight loss we have observed. And in
இதுதான் ஆல் இந்தியா கான்டெஸ்ட் மேபி இவளோட ஸ்லாட் நெக்ஸ்ட் மந்த்க்கு இருக்கலாம்.
Cynthia, can you please mute yourself? Thank you.
Here we have given a nutritional intervention goals to prevent the weight and muscle loss, and we are support like we have given you immune support and to reduce the infection and to overcome from the mucositis. The main goal is to take the patient oral intake because the patient is suffering from the mucositis. Can you please change the slide? Here we have implemented our nutritional support through we started TPN. On initiating on the day 6, we have started the TPN. It was continued for 6 days. Later, we have changed it. Really, it was taken 2 to 3 weeks to take a oral intake. Our target energy is 32 calories per day. It's approximately 1856 kilocalorie per day, and protein target is 1.5 to 1.8 grams of per kg body weight. Approximately, it was like 87 to 104 grams per day. And we are focused on the micronutrients and the fluid we have given 2.5 to 3 liters per day because the patient should require adequate hydration and additional support. We have given a regular mouthwash and cold blend feeds to manage the mucositis discomforts. Can you please change the slide? Here the monitoring and evaluation recommendations. After giving the nutritional support, we have monitored the patient regained 1.5 kg by 4 weeks, and the albumin levels we have observed by changing 2.6 to 3.3 grams per dl. And diet tolerance, he was having some oral feed, like soft, bland oral feeds, increased mobility and reduced fatigue. Actually, the patient is having fatigue and vomitings while admission. And short-term goals like mucositis, we have managed it and improved. And long-term support like chemotherapy. The patient is going under the chemotherapy, so we have planned for the chemotherapy itself. And recommendations, what we have suggested to the patient. While discharge, we have given high protein, bland oral diet, continued with multivitamins and zinc. Oral hygiene, we have explained about oral hygiene to overcome from the mucositis, and the main goal is patient have to take the oral diet and follow up is weekly diet. We have given the diets weekly when the patient attended to the chemotherapy, and our long-term goal is to maintain the muscle mass. Can you please change the slide? And the conclusion, here we have given a nutritional intervention while observing the patient condition. We have overcome the protein malnutrition. I'm not exactly saying the patient is well nourished, but we observed some changes while admission after the discharge. So actually here we can manage the nutrition. Sorry. Here mainly we are focused on the chemotherapy. While during the chemotherapy, patient lost the muscle loss and he developed the mucositis. We have given the adequate nutritional supplement to the patient as compared to before. After discharge, he was moderately nourished, and we have taken some subjective SGI to calculate the protein malnutrition, and we have planned his discharge diet according to the European and American guidelines. Can you please change the slide? Thank you.
Thank you so much, Anusha, for that presentation. Jury members, do you have any questions?
Yeah, Deepti ji, I have.
Yes,
Anusha,
please go ahead.
thanks for the presentation, Anusha. This was your patient, is it? You had worked for him? Hi, am I audible, Anusha? Hello. Am I audible?
Yes, Miss Shalini, you're audible, but I think Anusha is
Yes, ma'am.
muted.
Yes, ma'am. Yes, ma'am.
Okay, there we go.
Anusha, this was your patient. You had worked for
Yes,
him.
ma'am.
Acha. So can you tell me TPN rate? What was the TPN rate? How much was the requirement? How did you increase the rate? How did you reach?
Actually,
What?
I don't remember it, ma'am.
Okay. Was it normal triple back? TPN was normal triple chambered back.
Oh, yes, ma'am.
Okay. Okay. And what is the rationale behind using ideal body weight or actual body weight, which is used usually for energy? What do you usually use for energy calculation
Actually,
or protein
I have
calculation?
I've used ideal body weight, ma'am.
Why?
Because patient is already malnourished after the chemotherapy. So if I will use the actual body weight, it is like already patient is under malnourished and he lost the weight. So I need an ideal body weight so I can calculate through his I want to know exactly how many energy should the body required. So I have calculated with the ideal body weight, ma'am.
In case the patient is underweight, you should be taking actual body, ideal body weight, otherwise actual body weight. Because if he's already malnourished, underweight, here he is not, but just explaining, because then your target itself will be very less. Correct? Or there could be a refeeding issue. So you have to see
Ma'am?
what is the condition and what has to be selected. Is it actual or ideal? That one has to see and then go ahead. And what interventions should be done actually there when the patient has mucositis? What are the dietary interventions that we do?
Actually, we will go with a high protein diet and more zinc and vitamin C, magnesium. So to boost his immune system.
How do we give magnesium separately?
So it's through actually to supplement or through food, ma'am. But the patient is he was taking oral pill after 3 weeks. So we have started after 3 weeks only oral pill, ma'am. So there we have included zinc and magnesium foods.
What are magnesium rich foods?
Like we have included spinach, all green leafy vegetables.
Oh, thank you, Anushka.
Yeah, Anusha, thank you for the very good presentation. And I just want to know, at the time of discharge, did you advise any nutritional supplements along with the soft sodium diet?
Ah, yes, ma'am.
Yes. What's the supplements you advised, ma'am?
Advised proteinous and Selvida, ma'am.
Okay. How much percentage do you have done any calculations?
No, ma'am. Actually, I have advised the patient to take Selvida as a PD,
Okay.
2 scoops, and proteinous sachet along with the food per day, one sachet.
How many sachet per day?
Per day, one sachet, ma'am.
One sachet per day.
Mm.
One sachet will give 5 grams, no? So,
Yes, ma'am. 5 grams of protein. Along
yeah,
with that, he was taking Selvida.
okay. So how much proteins of
Selvida, in Selvida, actually, for 1 scoop, it was 2.3 or exactly 2.6, ma'am.
2.6? Okay. So total protein through supplements would be around 10 grams per day.
10 grams per day, ma'am.
Okay. Okay, ma'am. Okay, thank you. Thank you.
Miss Anita, do you have any questions? No? Okay. We will move on to our last presenter for today. Aarti, are you here? Good job, Anusha. Thank you so much for presenting.
Thank
Mhm. Aarti, are you here?
Yeah.
All right. Sai, can you please pull her presentation up? Anusha, you can mute yourself if you don't mind. Thank you. All
Shall I
right.
start?
Is this your first slide?
Yes.
Okay. Yeah. Please go ahead and get started, and your time starts now.
Okay. Good evening, Anandal present here. Thank you so much for giving this opportunity. I am the PhD scholar. This is my one of. Sorry. I'm the PhD scholar. This is my one of the paper in my PhD process, assessing the quality of life in chronic kidney disease patient on hemodialysis using kidney disease quality of life SF36 version 1.2 health survey. Aim of the study is assess the quality of life patient with CKD on hemodialysis more than 3 months in a dialysis center. Also identify the characteristic may be associated the worsening of life. Then material and method I used in this study is the cross-sectional study conducted in inpatient department. At the same time, the study is included 39 CKD patient as the systemic random sampling method for quantitative analysis. Short form kidney disease quality of life SF36 version 1.2 questionnaire were used to assess the health risk quality of life in CKD patient. Data were collected and analysis frequency tables, percentage analysis, statistics significant test as well. I am using SPSS and chi-square test. The area of the study conducted in Kolattur Dialysis Center, Chennai. Next slide, please. Okay, the inclusion criteria age above 18 years, the age up to 85 years, both male and females, CKD patient on hemodialysis for the more than 3 months, CKD patient with no other comorbids. Exclusion criteria, CKD patient is not on hemodialysis, above 85 years, both male and female, CKD patient below 3 months on dialysis, patient not willing for the study, at the same time too ill. Statistical analysis I can use in this descriptive statistics including frequency table, percentage mean and standard deviation, that and all. I am using the chi-square test one-way SPSS. At the same time, person correlation were evaluating the relationship between dimension of SF36 and different covariates. Statistics are demeted significant with the p-value under 0.5. Next slide, please. Okay, this is the tool I used in the study. This is the quality of life questionnaire SF36 version 1.2. This tool having 11 questions, each question having different kind of categories. Next slide. Okay, next slide. In this 11 question, I did the survey. Based on the survey, I will give some of the comparison at the demographic data and all. This is the resultant discussion. Demographic data, 62% of sample were male, 38% of sample were female. The majority were from male. Then distribution of age, 18% sample were below 50 years, 82% of sample were above 50 years. Next slide, please. Majorities was above 50 years. Next slide. Okay, this is the significant outcome based on my comparison. Kidney disease quality of life SF36 version 1.2. For the first comparison, I compare question number 4 and question number 5. In the question number 4, category B, and question number 5, category A. Overall, the question number 4 and 5 is related to emotional and physical health of the dialysis patient. The 66.7% had an emotional problem such as a feeling depressed, anxiety affect the physical health accomplished. less than regular work and other activity. So the I significant value is comparison. One is p value equal to 0.010. The meaning is the person having emotional problem is like while they going to the dialysis, each and every dialysis time they have some emotional illness, like depression, anxiety, that affect the physical regular activities. Next slide, please. The second comparison, I compare question number 4 and B category and question number 5 B category. It's 60% had both physical and emotional accomplished less than regular activity. There was a I significant in the comparison to the p value equal to 0.3. It's mean past 4 weeks the person going to the dialysis time, that physical and emotional problem, both things are affect the regular activity. The physical is not able to do the regular activity, that not able to do the regular activity affect the emotional that connected with the emotional things that affect the regular basis of dialysis. Next slide, please. In the comparison 3, I compare question number 4 C category with question number 5 A category. This one past 4 weeks, their physical health that affect the emotional problem as well as that affect the regular kind of work, and the limit it also shows limited time to spending with other activities. Like this is 72.2% had an emotional problem, which cut down their amount of time spent with work, affect their physical health, and limited in the kind of work. It's I significant in the comparison 3, p value less than or less than 0.001. The meaning is their physical and emotional problems affect the regular activity, so that that affect the regular activity at the same time is cut down the time to work with other activities. Next slide, please. The comparison 4, I compare question number 4 and question number 5 past 4 weeks, the regular daily activities that result of physical health, at the same time regular daily activity that affect the result of emotional problems. Like the 77.8% had a physical problem that limiting the kind of work due to affect the emotional problem. Did the person like a patient activities less carefully than usual. Usually they are doing some of the activity like going outside, spending time with the friends and family, going any function and all. After they come to the dialysis, regularly they going for 2 weekly, twice or thrice. Definitely the emotional and the physical, both the activities, like emotionally they are depressed, that affect the physical health, that two things affect the regular activity. That the patient, if they asking the patient those kind of question, they said I'm not able to go outside, so that feel more lonely for us. If I go to somewhere or some function, that affect my dialysis days. If it is in the dialysis state, I'm not able to go outside. If at the same time they said if I go any outstation, I'm not able to do my regular dialysis. So they said uh, the regular activities definitely affected us for this once they are enter into the dialysis. Next slide, please. The comparison 5, I compare question number 7 and 8. The past 4 weeks, how much body pain they feel. At the same time, that body pain, how it included in both work outside and home. At the same time, how it is affect the regular activities. Like 75% had a body pain during the past 4 weeks. That pain interfere with their normal work. So this was highly significant in the comparison 5 is p value less than or equal 0.01. Next slide, please. Okay, the comparison 6, the question number 11, category B and category D was compared. In this, the person said, my health, I am healthy as anybody I know. The D category is my health is excellent. If you ask the patient, they said if the patient coming to the dialysis, some of the patient coming with their a spouse, some of the patient coming with their father or mother, some of the patient coming with their caretaker. That time, if we asking any question, I know how my body pain, I know how to heat, everything they said. While we asking, they said the word is depressed word, like I know how to handle this and all, don't say do this do that and all. So that's a 40 percentage were said a statement, my health is excellent, I am healthy as anybody I know. But compared to the, I have totally 100%, 40% are understanding this is my problem, so I am able to do this and all, I am not able to do this and all, I will take care of myself. For 60 percentage people, they are not able to accept that pain and pain emotional connectivities. They are not able to do the regular activities, that and all they are not able to accept. So the p value is equal to 0.004. The next slide, please. Okay,
Aarti?
after this, yes ma'am.
You are last presenter, but you are up with your time. So just wrap up and finish up.
1 minute, ma'am. Yeah, 1
Mhm.
minute, ma'am.
Yep.
Okay. After this comparison and the survey, we plan to do some medical nutritional education. That medical nutrition education participant are patient with their family and caretaker, and we are the people of medical professional like doctor, nurse. We hire one psychiatrist, and as I am the clinical dietitian, I will in the medical nutrition education. Each one-on-one counseling we can do the patient with their family member. After the counseling, they understand what is the reality, how they will do the regular activity, how will they cope up with the dialysis at the same time the regular works. So finally, we conclude the medical nutritional therapy, the proper intervention, proper guidance from doctor, nurse, psychiatrist, and the clinical dietitian definitely improve the patient physical and emotional health. That help for the patient quality of life. Thank you so much.
Good one, Aarti.
This is the reference. Thank you.
Yeah. Very good. Very thoroughly done and very well referenced all over. Yes, Ms. Shalini, please go ahead with your questions.
Yeah. Thanks, Aarti, and good luck for your
Yes, ma'am.
PhD.
Yeah, thank you. Yes, ma'am. Thank you.
It's a nice topic, and we see what's the practicality which happens with the dialysis patient. And
Yes,
we
ma'am.
have done studies on this. So I
Yes.
wanted to just, for everybody to understand what is the common emotion you feel when you speak to the attenders. What do you think?
While we speaking to the attenders, we are giving more restriction to the patient. As a dietitian, I said don't take potassium rich food, don't take salt, avoid oily spicy food, avoid too much of taking of water. That time, if we tell to the attender, they said, I'm able to understand what you said. You will give the diet chart. Whatever I will make the food, but I will give it to the patient, they are not able to accept. Why I am after taking less salt food? Why you restrict me? Why restrict that? That and all they will. Then slowly, once the coordination is more important, ma'am, for the attender and the patient, because if the doctor said they accept, if the dietitian they doesn't. So in the coordination with the doctor, nurse, and the dietitian, we are working coordinately. We will say the same thing to the
Right.
patient. Definitely, they will understand.
Just to add on the same thing, yes. So I feel there are two categories of patients. There are few,
Yes,
the
ma'am.
attenders, there are few who are over restrictive. Under the umbrella of care, they kind
Yes,
of
ma'am.
over
Yes,
restrict
ma'am.
the
Yes,
patient.
ma'am.
Yeah. So that makes the patient much more malnourished. Patient himself restrict himself. That self-imposed restraints are there that pushes them to malnutrition. So patients usually die because of malnutrition rather than CKD issues.
Yes, ma'am. Yes, ma'am.
So
Yes, ma'am.
this intervention is best
Because
when
we
you
also restrict some protein. They understand all the things and all protein. If they're taking protein rich food, they said creatine level should be goes high. It increase the fluid overload like that.
yeah.
They are not
But
able to categorize the protein. Which protein is good, which protein is not taking. They have to take non-vegetarian, but they have a global word. They search it in the Google, they put creatine, which are the protein food or increase the creatine. It comes under list of food they avoid completely.
Yeah. So, but at the same time, we have to be little less restrictive. We have to be more inclusive in nature than
Yes, ma'am.
exclusive.
Yes, ma'am.
If potassium rich for food also, if you're taking just once a day rather than leaching and doing things like that, if we are practical enough in our approach, probably that will help them more so that they can at least eat the food they want. And such support system are the best when they hear their peer groups, because whenever you do, because when they are in the dialysis unit and the attendants are sitting outside, or you do a separate session where you call everybody together and do a support system the way you did.
That's why
Intermittent
we conducting that
Yeah.
session, M&D session, ma'am. We call the patient first. We ask patient side what you facing the problem. Then we call the attender. We that talk was a friendly talk, ma'am. This was he need. You can prepare like that. So then the patient and attender, both of them understand, ma'am. That
True,
time.
true. So it's all about management. So even a
Yes,
patient
ma'am.
who is CKD not on dialysis also can prolong his life without dialysis.
Yes, ma'am.
On dialysis also can maintain. So
Yes,
it's, yeah,
ma'am.
it's
Yes, ma'am.
nice. Thank you for that, Aarti. Thank you.
Thank you. Thank you, ma'am.
Anyone else have any questions for Aarti? Miss Anita or Miss Padmavati? No questions. I know we also have one of our senior dietitians, Ms. Dr. Esther Satiraj on the Zoom today. If you have any questions, you can go ahead as well, or anyone else. We are pretty done with presentations for today. I'm just going to give 30 seconds, not more than that. Okay, if anyone has any questions. I hope Miss Anita and Miss Padmavati, you are okay and you're not having any technical difficulties. Yeah, okay.
Okay,
That's fine.
ma'am. Yeah, okay.
Yeah,
Fine.
yeah. All right. Great. Just making sure that, we have you covered. All right. I think it was wonderful to see everybody present. Aarti, good job, by the way. Good luck with
Thank
your
you.
PhD.
Thank you.
Very compassionate topic, and you're doing good. It's hard to be where you are, but you are doing good. So thank you so much, everybody, for being here today for another interesting set of case studies that have been presented by these young dietitians from all over India. Each of them had a very good case study to present today, and it was interesting to see their take on the case studies, and our judges were amazing, and they had spot on questions for these contestants. What we will do as next steps is we will consolidate the evaluations from all our jury members, and once we have a final score, we are going to announce the winner in the social media, and we will get ready for the next set of presentations next month. All right. So if you know anybody who would be willing to present a case study, or if you would like to be the one who want to present, please feel free to contact either Sai or Raju. And there is a WhatsApp group as well where we post. Please circulate the word about this contest. It's extremely a wonderful opportunity to present in front of the senior dietitians. This is how we learn. Opportunities like this are very rare. And I also would like to thank all the Pulse team for coming up with this very interesting initiative to have the case studies presented month on month, identify students, identify jury members, and put all of this together. It takes a lot, but I really would like to thank the Pulse team on behalf of NHF. Thank you so much, everybody. And we will meet in another set of presentations in the New Year's. Everybody have a very happy holiday season and a happy New Year to everybody. Thank you.
You wish you the same.
Thank you so much. Bye-bye.
Yes, thank you very much for